Well, good morning. How are you? Energized? Good. Well, first of all, thank you, Robin. Thank you, all of you, for coming here today. It is just delightful for me to be here. You can't imagine how much energy we get as clinical research from all of you. In fact, you were the ones that kind of took me through the path that I'm in. I wasn't planning to study PSP. I wasn't planning to study all the typical Parkinsonian disorders. It just happened that as soon as I would do one study, my patients will call me and say, "So what's the next? What's the next?" So, with that, and with all the questions that each study has, I keep going and going and going, and the questions continue to multiply. So today, I'll be giving you an overview of what we think today with our own doubts, so you may see why it takes somehow long to get the diagnosis and all the features that at times comes to be a disease. And more importantly, that even when that happens, that we can still make mistakes. Because really only when someone passes away and we get the autopsy results is when we truly know what is the real diagnosis. So even if we're careful, we still can make mistakes. Obviously, that if we're careful, we make less mistakes than if we're not. So we tend to do long exams, and some of you may know that. So I'm sorry for the lengthy time, but we want to try to take care of all the aspects from the patient as well as from the caregiver point of view. So let me start by telling you that first I'm going to just go with a definition. What is Parkinsonism? What is atypical? And then go on into what are the clinical characteristics of the disorders and what are the overlapping features, why some are more confused with others, and why some may stand out more than others, as well as what are the markers that can help us make an early diagnosis, that is truly what we all want. An early diagnosis so we have a peace of mind, we know what to expect, we know how to prevent complications, we know how to try to get into clinical research studies and try to learn more about the disease so we can eventually hope what you all hope, cure, or even not have it at all. So that's really the main reason of early diagnosis. So we try to provide the best care possible. We try to get the maximum possibilities for research regarding understanding a disease, as well as understanding what are the possible ways of either prevent it or stopping it. Most of the studies do show that when we look at the pathology, there are certain diseases in which major errors are committed. The major one is corticobasal degeneration. That is where most of the errors occur. Then there are others, and dementia with Lewy bodies, I would say, is the second one, and perhaps multiple system atrophy and as well PSP. But what is it that is Parkinsonism is the major question. So what you see here is someone walking with a small step gait without associated arm swing. And that is kind of the characteristics, I would say, of what slowness and low amplitude of movement is. And that is a key feature for Parkinsonism. That feature also associates with either having tremor at rest that has a certain frequency, or may associate with stiffness or with postural instability. That really is a whole category, like if you were to call furniture. But what is the furniture that I have? Is it that a chair, a desk? So that's kind of what all the different disorders are. And so we first characterize them as secondary to something, secondary to drugs, secondary to strokes, secondary to infections. And once we rule those out, then there are these progressive disorders that happen as we age, and those are the neurodegenerative diseases. Diseases in which cells in certain areas of the brain die, and most of the time we don't know why. So why is it that some of them are Parkinson's disease and the other ones are the atypical? Well, the Parkinsonism, that is the slowness, the rest tremor, or the rigidity, that kind of gets us to the Parkinson's disease type with a very excellent response to dopaminergic medication, and none of the other features that we call atypical. So let me go there. Those atypical features are those that are not in Parkinson's disease, and that's why they're called atypicals. And why is that classification, or why is that name? Well, the name is because Parkinson's disease ends up being the most frequent one and the one that most doctors diagnose. Many of you may have been diagnosed as having Parkinson's disease, and eventually you are told, oh, this does not seem like it, and maybe this is one of the atypicals. So atypicals is because there is a falls early on in the course of the disease, because there is no response to dopamine, because there is a rapid progression and someone may be very early wheelchair bound. That doesn't really happen in Parkinson's disease. And because there could be some problems when you stand up and the blood pressure falls, or because there are urinary problems early on, even before all the symptoms occur, or because the walking is very wide-based, or because there is some tremors when you move your arms, or because there is dementia early on, some lack of memory that is significant, or difficulty with planning and multitasking. That's kind of what Robin was saying. The planning of a trip, right? Sure, her dad had been traveling before and knew that he had to have money, but there is a lack of planning. And so you kind of do the things and think that they're going to be all there, when in fact you cannot really plan ahead. That's truly what an executive person do, and that's why those functions are called executive functions. It is also difficult at times because there is other problems, such as visuospatial problems, or there are difficulties handling things, or there's some jerking that doesn't exist in Parkinson's disease. So let me give you an example of what falls are. We ask you all the questions when we are doing our examinations regarding when did the things happen, because when they happen allow us to make a diagnosis. If falls occur very close to the start, it's the first symptom, pretty much within the first year of the symptoms that you identify on something new, that makes us think right away, is this PSP? If the falls occur but not immediately within the first 2 years, that still allow us to think on PSP, but MSA comes more into our thoughts as well. If the falls are there, but it's not really necessarily the first symptom, then corticobasal degeneration comes there, and dementia with Lewy bodies come there. But we certainly don't expect Parkinson's disease patients to fall early on. And that's how we divide and we start thinking about it when you are telling us a story. Another thing is, well, we see someone already coming with a fracture, and that's kind of the first doctor that sees, or many others have seen this person has been falling and comes with a fracture and comes in a wheelchair. We already are thinking, this is not Parkinson's disease to start with. I'm already thinking my index of suspicion is already very high. You may have heard about the oculomotor problems. So what are they? Here is the first patient that Steele, Richardson, and Olszewski saw. And you can see that this person can horizontally follow a pen, but not vertically. And that is the supranuclear gaze palsy, the difficulty to look up and down, and the difficulties that that leads to is really difficulty reading, because to read, you need these rapid eye movements going up and down. And that's why reading is also an early feature. And people just think that I lost my interest in reading. Well, it goes a little bit beyond that. In fact, the difficulty is voluntarily moving the eyes. And that's why this person wants to look at his watch and cannot do so. And so the examiner comes and helps, but truly it's difficult for the person unless they really raise their hand to look at his own watch. This supranuclear gaze palsy, we said, oh, now we know that's PSP. Well, not always. Not always. At times, these are other diseases. So as neurologists, that's our task, not yours. You're the ones to tell us what are the problems. So we are to try to put it in context. So at times, it happens that this happens in families, and they have a familial disease that is the frontotemporal dementia with Parkinsonism that can present like PSP, but then there is a family history. Or it could be that there's people that may have an infection, and that's Whipple's disease, or may be that they live in Guam and they have the Guam lytigo-bodic disease, as it's called in Guam. But these are the classical features of PSP. When we make that diagnosis and when all these features are, the disease has progressed for at least 3 or 4 years. That's a lot of time. We want to make that diagnosis so much earlier than that. So yes, that's how it was described, and that's what we call it, classical PSP or Richardson syndrome or SRO, whatever you want to call it. Everybody calls it a different name. But basically it's the presence of these falls, the postural instability, the vertical supranuclear gaze palsy, the difficulty speaking, the difficulty swallowing early on, as well as these frontal disturbances, that is, our executive dysfunction, our difficulty in planning, multitasking, having an abstract thought. We become much more concrete. So early on, we realized that there were things happening before that, and that is, in fact, probably I should go, I cannot see my slides here well. So let me explain to you what I'm gonna ask you to see. We realized that before those symptoms occur, there were other symptoms occurring with the eye movements that would allow us to try to diagnose the disease earlier. And those are the saccades. So what are the saccades? Rapid eye movements between two stimuli in which we see the eyeball moving so fast that we see the starting of the movement and then the end of the movement. But we don't see pretty much the eyeball moving from one side to another. So if someone had an infection, an encephalitis, that's not PSP. If they had problems with hallucinations early on without any medication, that's not PSP either. If they have a clear dementia with language difficulties or significant memory problems, that's not PSP. If they had significant asymmetries, one side more than the other, we thought that's not PSP. In fact, we thought that having the symptoms of not feeling well when there were two sides being stimulated, or having difficulties manipulating objects, that is the apraxia, when there is no problems motorically, or having the dystonia, all those were real exclusionary criteria because those were the typical features of corticobasal degeneration. But nowadays, that is also a form of presentation of PSP. So before we thought, oh, we exclude those because that's the way to exclude PSP patients that have the real disease versus those that have CBD. Well, nowadays that's not so clear. Some patients with PSP may have the corticobasal syndrome. In fact, there are other presentations of PSP. That's why that criteria we put forward is what we call specific. Once we say that they have, someone has the presentation of PSP Richardson or PSP classical, that is PSP almost all the time. But if they have something else, we were not able to diagnose, and that's why the criteria was not sensitive enough. There were people that had PSP and we were not able to diagnose. So that's how over these past few years, all the other phenotypes, all the other presentations came about. One of them is the freezing of gait. People that just have difficulty with getting stuck in the floor when they're turning initially, and then this freezing gets worse and worse. This patient had PSP. She had it for 15 years. She had a pretty much normal life except for that. And later on, she developed the features of PSP. Later on, she had the problems falling, and she eventually had the problems with the eye movements. And when she passed away, we learned she had PSP. And this is another form of PSP, that is the akinesia or freezing of gait form that has a much better prognosis. So that's why it's important to know the different types of presentations, because they may have different prognosis. Another one is the corticobasal syndrome. And in fact, this is one of the patients of Richardson. This is in fact one of my patients.
My main problem is my right hand and arm that I can't use.
When did that start?
I think about 3 years ago.
What did you notice then?
Well, I went to an arthritis doctor for my writing. It started with my writing. I was losing control of the writing. Then it was hard for me to cut my food. See, I'm right-handed, and it was hard for me to cut my food and to eat with my right hand. The hand started to jump. Not so much shaking as jumping.
That's myoclonus.
And I couldn't control
She couldn't describe it better.
Could you see that at times the hand would be moving on its own and you wouldn't realize that it was
Yes,
moving?
especially at night in bed. I would wake up and the hand would be up.
Would you also feel at times that your own arm was not your own arm?
The right arm, yes.
So that truly is what we call the alien limb syndrome, feeling that your arm is not your arm and it does things that you're not expecting. That is different than having a jerk as she described it. I use this tape to teach my students because there's nobody that can be clearer than her. She clearly differentiates what is a rhythmic movement, the tremor, from that jerk that happens when myoclonus occur. She also describes how she lost her way of writing, but she could move her hand. She couldn't fold things, but she could move her hands. And that is part of the apraxia. Like if you lose the way of doing things, things that we obviously all do automatically become quite hard to do. Even if you know what to do, you cannot do them. So that is the apraxia itself. And that's very typical of corticobasal degeneration. And not this patient truly had corticobasal degeneration. And there is another form that I skip, but is the PSP Parkinsonism. That is someone that really starts with Parkinson's disease-like symptoms. Really the tremor, the rigidity, that stiffness, the slowing, but then years later develops all the other features of classical PSP. And that is the PSP Parkinsonism that we cannot diagnose early on. There's no way, because patients really respond to the medication as it would be Parkinson's disease patients. And only later on, they stop responding to the medication and they start having the eye problems. So that's when we can make the diagnosis. It's a diagnosis that we make that is retrospective in some ways. We need to have had that history. So coming back to corticobasal degeneration, that's the way that it was described in 1969, the corticobasal syndrome, as the typical way that corticobasal presented. But as I show you, one of the patients that Steele, Richardson, and Olszewski in the typical paper, when they describe this disease, already had this presentation. They just didn't pay attention because all the others didn't. It's not as frequent, but that patient also had PSP. So what happens with corticobasal syndrome, that we learn that there are many other diseases that present like that. One is PSP, another one is Alzheimer's, and there are many others that present and are truly forms of a presentation of corticobasal degeneration, but the pathology is the one that tells us. And that's why I told you early on, that's the hardest diagnosis to make. Corticobasal degeneration also presents with other forms. So, as I was mentioning, corticobasal syndrome could be corticobasal degeneration, PSP. It could be non-even a tauopathy. It could be Alzheimer's. It could be dementia with Lewy body. So it could be almost anything. So nowadays, this is recent data from the Mayo Clinic Brain Bank. And actually, if you really can see, the corticobasal syndrome, only less than a quarter of the patients had truly corticobasal degeneration, and almost half had PSP. Of course, this is a PSP brain bank, so there may be some bias there. But still, Dr. Dixon says that he gets brains from all over and not all of them have PSP. So clearly, it does occur that not only in his data, but in other centers, having difficulty with executive function, but also becoming more apathetic, with as if you have less interest. In fact, that is also true. Not depression, but lack of interest in things that someone used to have a lot of interest in, that not necessarily go along with not being able to do them. It's just beyond that. That's what we call apathy. And as I said, the PSP syndrome. There are some patients with corticobasal degeneration that have PSP presenting. So this is just from one brain bank, and this is the brain bank from the University of Pennsylvania, and I just marked from 15 patients, only 4 of them had the corticobasal syndrome. All others had all the other presentations that I was just referring to. So it is seen in many more places than that all the data is showing that. So what is the commonality between PSP and corticobasal degeneration? Well, it happens to be that they have a lot of things in common. Not only they overlap in history, as you saw, some of the syndromes are the same, but also when you look at the brains, the neurons and the glia, all the cells in the brain that we can see that are affected, have a protein that is called tau, that is part of the cell, part of the membranes of the cells, part of the pipelines of the cells, aggregates, kind of agglutinates. And so that allows the cell not to receive the proper nourishment and the cell dies. So those clumps are in the neurons what we call neurofibrillary tangles, and they form in PSP because in the other cells that nourish the neurons, that is the glia, they kind of clump not only the body of the cells, but also its extensions. They form this tufted astrocyte in PSP. And in corticobasal degeneration, because these tau clumps accumulate more in the extensions of the cells but not in the body, they form what they call the astrocytic plaque. And that's pretty much the distinction between one and another, because as you saw, even location can be similar. So it ends up being this what really allows the differentiation when you look at the pathology from one disease to another. Even genetically, there are similar things. So these two are what we call, normally we have 2 forms of tau in the brain, 3 repeats and 4 repeats. And here in corticobasal degeneration and in PSP, the 4 repeat tau is the one that accumulates the most and makes the cell, the tau aggregate. And that's what this happens. And interestingly, this is different than what happens in Alzheimer's disease and what happens in other frontotemporal dementias. So there is this overlap. We have the clinical features, we have the corticobasal syndrome, the PSP presentation, the frontal dementia presentation that both have in common. So are they the same disease or they're different diseases? And that's still the judge is to be made in the future. We don't truly know. I believe there are different diseases, and certainly it's worthwhile separate them, because maybe what happens is that these 2 forms of the same disease or of different diseases may have different genetics or different environmental factors, and we will not be able to know what leads to one disease presentation or the other unless we really study and keep them separated. So let me go now to the other disorders. The MSA is the other disorder that I'm going to be touching about now, and it's a gradual disorder. Usually the presentation is a little bit earlier. What happens here is that we have a lot of what we call autonomic disturbances, urinary disturbances that are significant, problems with erectile dysfunction, and some of the patients may end up having Parkinsonism, others may have the kind of type of drunk gait, this white-based gait, and that's how we call it MSA Parkinsonism or MSA cerebellar.
That off and on.
This is one of our patients. Impotence, was that a problem also?
Yeah, that was a problem.
Feeling woozy?
That's not been much of a problem.
your blood pressure was, when you were lying down, 167/79, but then when you got up, your blood pressure came to be 95/59. So it really, there is a big...
It fluctuated a lot.
So this patient thought that, or he was diagnosed as having Parkinson's disease, and he thought, as he didn't have any other reason to think, that all these blood pressure problems and impotence were related to something else. They were unrelated, or he was getting old. That's pretty much usually what people think. I'm getting old and that's why I fall. I'm getting old and that's why I have tremors. But it happens to be that these symptoms truly are the autonomic symptoms, are the ones that precede even the development of the Parkinsonism and allow us to separate these diseases. So if they present early on, we think on multiple system atrophy, we think on dementia with Lewy bodies, but if they present late, we think on Parkinson's disease. And usually, the problems, particularly with the blood pressure, not the urinary problems that are for different reasons, but the problems with the blood pressure dropping when you stand up quickly, that doesn't happen in PSP, that doesn't happen in corticobasal degeneration, unless you have medications, but usually doesn't happen. So I have them in two different colors, and I have them all in red. And I have them in red, the multiple system atrophy, the Parkinson's disease, and the dementia with Lewy body. And I have them in red because of a reason. They all have the same protein that deposits into the brain when you look at the brain, and that is alpha-synuclein. So the fact that alpha-synuclein is the commonality already gives us some sense that they're going to be shared symptoms. And of course they are. They may occur at different times, but the symptoms are shared and overlap as well. So we see that this is from actually cases in which we look at the pathology. And we could see that MSA, even PSP and dementia with Lewy bodies, all of them had intermediate problems with blood early, and then intermediate problems with the blood pressure dropping. But in the PSP cases, truly that is only by autopsy where things have not been recorded well. That is really not what happens in our clinical life, I have to say. The urinary problems, yes, they do exist early on in MSA, and as I said, intermediate in the others, and very late in Parkinson's disease. So I mentioned the important part of the Parkinsonism that occurs with MSA. One of the major things is that these patients may, at times, respond to dopaminergic medication. So it is important that they try it, even if the blood pressure falls. So that is very, very relevant. The MSA-C, we said, is a gait that is very wide-based. They may have a tremor, and this is exactly what I'm referring with that cerebellar tremor. It's a tremor that exists as you move your arm. That makes you have more difficulties when you're trying to eat. That is different than the tremor that occurs in Parkinson's disease. Cerebellar disturbances also occur in other diseases. And finally, dementia with Lewy bodies, in which there are several things. Dementia and Parkinsonism arbitrarily have to happen within a year, or at least when Parkinsonism occurs. First, dementia has to occur within a year to call it dementia with Lewy bodies, and later on, if it's going to be Parkinson's disease and dementia. But one of the major features is the fluctuations in the cognition, fluctuations in the motor aspects, and people really say that the fluctuations are very significant. And at times, my spouse is doing great, and at times they're not doing so great. And they play golf, and they did great with their friends, but later on, they were really confused. And that's very typical of dementia with Lewy bodies. It is also typical having hallucinations, seeing things that are not there, not scary things, just things like a dog that passes by or something that comes and goes, and then it may get worse. And they also may have very frequently what we call REM behavior disorder. That is, when you sleep, you're having dreams and you're acting out those dreams. It's important to have this diagnosis very early because patients are very sensitive to medications, to neuroleptics. So they may develop major complications, what is called the neuroleptic malignant syndrome, if they take these medications. And that is a condition that is life-threatening. And these are not all the neuroleptics, but the old ones, like Haldol. So that is something that people that have dementia with Lewy body should always say when they go to an emergency room, because if the problems are hallucinations, that would be something that could be treated in the wrong way. So as I said, alpha-synuclein is in the cells in Lewy bodies in Parkinson's disease, as well as in the cortex in dementia with Lewy bodies. But in multiple system atrophy, it's in the glia, in the other nourishing cells that are nearby. There are several things that also overlap here. The blood pressure drops, the urinary problems, the cognitive problems that may occur, the Parkinsonism that may respond to levodopa therapy. So all this, the fact that it's asymmetric, so all these clinical features, the fact that there is alpha-synuclein also in the brain, also led to think, are they different disorders or they're not? Whether they are or they are not is still important, because if we do find treatments for these proteins that agglutinate in the cell, in the brain, then we can treat all these disorders, those that have the presentation with MSA, with treatments that would go against the alpha-synuclein agglutination, and those that have PSP or CBD with treatments that would avoid the agglutinations of tau. So that's why it's still relevant to separate them at least in these two major groups. But there are features that do not fit into any of them, like there is dystonia that is axial in multiple system atrophy, there is scoliosis, there is what we call anterocholis, but there is also anterocholis and what we call retrocholis in PSP. So even these diseases that have different proteins aggregated in the brain, they have overlapping features, and that makes it difficult. There are also other signs, reflexes that are abnormal and maybe in all of them. So what do we do to work up, and what are the biological markers? Well, unfortunately, we don't have biological markers. We don't have, like in diabetes, that we draw the blood and we can say, oh, this is diabetes. That doesn't happen. We have MRIs, and each MRI may help diagnose one disease versus another, but not all of the people do have these abnormalities. So in PSP, there may be this midbrain where all the lesions are that is small. In MSA, it may be the opposite. It is the pons, the one that is small. But again, this is not really a complete marker. And I'm going to go over all these different features that truly are not of relevance here. It's just for you to know. There are features that may help point to one disease or another, that truly what they represent is the anatomy of the lesions. So in corticobasal degeneration, for example, one side of the brain is much more atrophic than the other, and that's what you can see here. You can see more black spaces. The white and is where the brain is, and you can see that here is much more atrophic than here because the person had the symptoms on the other side, that is crossed in what we have in the brain from what we have in the symptomatology. So there are symptoms as well for multiple system atrophy, but again, all these symptoms just reflect where the lesions are. So in PSP, we have this small brainstem, this small mesencephalon, because this is where all these dark lesions that explain the eye movement problems are, and where the lesions in the substantia nigra are that explain all the problems with the Parkinsonism. So they just reflect where the lesions are, but they don't tell us what is the protein that is there, that is what would allow us to really know this is this disease, this is that disease. Transcranial sonography is being done in Europe. We don't have that. They claim it is very good. We don't know that yet, but apparently it may be very hard to learn how to do it. The spinal fluid, there are some studies that suggest that certain protein ratios may be typical more of PSP than the other diseases, but again, these are not really markers that we have in clinic. They're still experimental. So participation in studies is relevant because it can help get us there, get us understanding what is different between one disease and the other. So this is what I try to tell you, that Parkinsonism is divided in secondary when we do know what is the cause, strokes, drugs, neurodegenerative, the Parkinson's type, the typical ones, and all these different disorders that usually are sporadic, but there are familial atypical Parkinsonian disorders. They're rare, less than 5%. In conclusion, we can say that it is important to know that there is a spectrum of symptoms in all these disorders that may overlap, but it's still important to keep them separate. It is still important to try our best to make the best diagnosis as early as possible so you can get the best treatment and you know what your prognosis is going to be. It also is important because the symptoms may lead to having a complete different prognosis from one to another. We do want a lot of research that can allow us to really find markers that could differentiate these different disorders, as well as trying to find treatments that can really one day, hopefully, make these diseases either slow down completely or disappear. Thank you for your attention. I'm happy to be here and answer all your questions.
See if we can get your other microphone to work. Otherwise, we'll share. Is Randy here? Can we? Yep. Can you help Dr. Litvan get the lavalier microphone working? Then we won't have to share. If any of you have question cards, please raise your hands. I see a couple over here, 3 or 4. Our volunteers can get around.
Actually, the mic is working. So you've got it on this lapel. And when you look that way, the mic's over there.
Really?
But I was over there and I was looking down though. I was looking down. When I was down there, I was looking down and it still wasn't working.
Yeah, I never heard it.
I mean, I never heard one
Yeah,
sound.
me neither.
Because ideally, it should be right in the middle.
But still.
Yeah, I don't
It's
hear
not
it.
on yet.
Oh.
It wasn't red ever. Now it is.
Yeah, we never heard of it. Okay, great. Thanks, Randy.
Thank you.
Okay, we've got a few questions already. So the first question is, where do the diagnostic features get decided? How does the latest thinking get disseminated to clinicians in non-academic settings?
Oh, that's a wonderful question. That's where CMEs are about, continuous medical education is about, and that's what we try to do all the time. So I have to say that since I arrived to California a year ago, we had 3 CME events in which we
teach healthcare professionals that are in the community. We truly want that the people would recognize right away this disease. But at times it's hard to get all these physicians to go, particularly because if you do fall, you're going to go to an orthopedic surgeon, right? So why would the orthopedic surgeon know? In fact, I had one of my students going by, and when he was being taught what Parkinsonism was, he said, oh, I was in orthopedics like last month, and I saw a lot of patients that have what you're telling me, but they never were diagnosed. And that's what happens. You know, some of the specialties will never know. So it is difficult. So if you do have a very good primary physician that truly goes and tries to get the best and more up-to-date knowledge, then you're lucky. Obviously, how would you know that you need to go to a neurologist when you're falling? It's really difficult. Or that you have to go to a neurologist when you have an eye problem, or that when you have a urinary problem, you have to go to a neurologist. I mean, it's contraintuitive. So it's going to take us a while to get there.
Okay, next question is, are these diseases fatal, or does the patient die of some other disease or event?
The latter is the truth. That is, these diseases are not fatal per se. What happens is that we develop complications of the disease. That is, we have swallowing problems, food goes into the wrong pipe, we develop aspiration, and we may die out of that. Food can go in small pieces into the wrong pipe, we develop repetitive pneumonias that are difficult to treat. So swallowing problems is a major cause. And that's why I always recommend that you truly are looking and seeing if swallowing is a problem. And how do you know if it is a problem? Well, if you are coughing when you're drinking, that is a problem. So you need to get your doctor to know and do a modified barium swallow, a study that allows you to learn how food can be swallowed with different consistency, or how different consistencies of food are going through the right pipes. So usually in neurological disorders, the major problem is swallowing liquids, not solids, liquids. So if that is a problem, these studies can allow you to figure that out. And once you have that problem, it's important for you to be every so often having that study, every 6 months, a year, depending on your symptoms. If they are stable with whatever it is that they're suggesting you to do, then maybe you can wait a year or so. But it is important to be really, that's what we meant by getting the proper treatment. Really trying to go and try to avoid complications. Another complication is falling. So you fall, you get a fracture, and you get into the hospital, and you get all the complications that go with being lying down and having a clot in your leg or anything else, or having more problems because you fall and have a head injury and so on and so forth. So it is the complications for the symptoms, not the disease per se. The disease does not affect the breathing, does not affect necessarily the heart per se, that would be the organs that would, most readily make you think that you're having a problem with something that is going to kill you.
Okay, the next question is, when you autopsy the brain, is it possible to have multiple findings? For example, can one have both PSP and dementia with Lewy bodies? How subtle are these diagnoses?
Yes, that's a very good question as well. Because yes, we can have more than one diagnosis. And this depends on how good our techniques are to look at these proteins that are aggregating the cells, these agglutinated proteins in the different areas of the brain. If someone doesn't look for something, you don't find it, right? So here it is important that you look for them. So at times there are Lewy bodies that accompany PSP. So yes, they do occur, and those are the PSP patients that have hallucinations. So I've seen those, very, very rare. but does occur. So there is overlap at times. It is said that there is a fatal attraction among proteins, that once one agglutinates, leads to others to agglutinate. And that's why at times you have more than one protein agglutinating. That's why in dementia with Lewy bodies, at times you do have Alzheimer's disease. It's in fact at times frequent that that association may exist. So that is what is meant by fatal attraction in some ways.
Okay, we have two questions related to imaging. First, about MRIs using to diagnose Parkinsonism, atypical Parkinsonism, and also the new DAT scan.
All right, maybe let's start with the DAT scan that is the easiest. The DAT scan only allows you to say that somebody has Parkinsonism, but it doesn't allow you to differentiate these different disorders. They pretty much all look alike. So do you really need a DAT scan? Not really, because whether you have MSA, whether you have PSP, whether you have the LBD, they will all look alike. So it's not going to help you at this point. If you're slow and if you have tremors or stiffness, you already know that you have Parkinsonism. So that step is not needed. And it's a lot of money that is not needed to be spent. On the other hand, the MRI, it does show some features that are, as you saw, somehow pointing or supporting the diagnosis of the disease. So in Parkinson's disease, the MRI is normal. All the MRIs we can do at present are pretty much normal. But in MSA, you saw that there are certain characteristics. In PSP, there are others. So it does help to find things that will support your clinical diagnosis. But as I show you, well, I don't think I show you, but I will show the people that will come to our CBD discussion later on, that at times even the MRI looks exactly as the patient looks, and they may have the corticobasal syndrome with that atrophy that corresponds to corticobasal syndrome, contralateral to the major symptoms, but then the diagnosis is still Alzheimer's disease. It's not corticobasal degeneration. So what it really points is to where the lesions are in the brain. It points to the atrophy that corresponds to where the lesions are and the shrinkage of that particular area of the brain.
Okay, you mentioned you get information from autopsies of brain tissue. Where do the brain samples come from? Are they donated? If so, how do you go about donating your brain? Would you give the information to the family after the brain has been donated?
Well, what I meant before was a study we did with multiple centers across the world, and that each center gave us the pathological samples, and they gave us also the clinical information, and that's how we were able to put together both, and we were able to come up and help make the different diagnostic criteria. So by looking at the accuracy in diagnosing, when you put both of them together, you come up with better diagnostic criteria. How do you do about that? Well, that is a major gift. That's a gift of life. It's a gift of life for you, it's a gift of life for us, because as researchers, we truly value knowing what is the diagnosis that someone had. And usually all the centers can help, but if there is nobody that does, I always try to link people with the Mayo Clinic. And Robin was telling me before that she does that very well. So Robin can be a resource. I'm in the internet, I can help you as well. This is usually something that would help researchers always, particularly if we do have the clinical features from before. So it is usually important that where you are being studied, if it is in an academic center, that you let the people that are following you to know that this is what you want to do. I was explaining that for us as physicians, it's really very hard at times to say, well, you know, we get to the diagnosis when we see the brain, and you are feeling like, I don't want you to misunderstand. I don't want your brain now. I want it whenever it happens. but it's really an odd feeling. You're always afraid that someone may misunderstand you. And so at times, if you can bring it up, it's so much better. You make the physician happy, and you make yourself happy. And as I said, it's a gift of life. Thank you.
Okay, thank you. And I would also just like to say that Brain Support Network helps facilitate brain donation arrangements. And there's a flyer on the table outside if you're interested. We've helped 125 families successfully donate brains, mostly to the Mayo Clinic, as Dr. Litvan mentioned. Here's a somewhat related question. How often is the diagnosis of these diseases put on death certificates so it can be followed in a database, and is that important?
Unfortunately, the certificates are not really good, because usually what they have is the cause of death, but it doesn't really say, and the accuracy of those is very limited. So there have been several studies that try to put together what is the accuracy of diagnosis based on pathology versus that is being put into a death certificate, and it doesn't help. Physicians that do it at the last minute, they just put whatever the family says, and they're not going to go to look for something that would support the diagnosis, or may not even put it there. So that's unfortunately not a good way to go.
Is there any research on possible causes for these disorders?
Multiple. That's the hope. That's the hope that comes. There is a lot of research into trying to understand the causes of this disease. As Robin had mentioned, we do have a large study. It's a NIH-funded study in which we are collecting the information regarding genetics, doing blood drawings, and environmental factors, occupational factors of people that have PSP, and their loved ones, the caregivers, as well as a control that they choose, usually somebody that is an in-law, if possible, matched by age to the patient. And we're discovering, in fact, a lot of interesting and important things. Environmental exposures do count, and genetics does count. So it is important, because I envision a world in which we may know our predispositions, and maybe if we know what is it that leads us to have these proteins aggregate and have these diseases, maybe we can avoid that kind of a job or that kind of exposure, and maybe we avoid the disease altogether. But the studies occur. We have one that is multicentric in several centers in the United States. And there are studies for Parkinson's. There have been studies for multiple system atrophy. I'm not aware of any for dementia with Lewy bodies that I am not aware of. And the problem with corticobasal degeneration is that we don't have an accurate diagnosis. So that's why before going into those type of studies, what we decided to do is let's try to get an accurate diagnosis, and then from then we can move on into trying to get the right studies. So research is limited by the accuracy of diagnosis, because if we don't know ahead of time, we cannot ask you things that are worthwhile, because as you know, garbage in is garbage out. So whatever you put in, you're going to get out of that. And so we need accurate diagnosis to make advances in science. And if we know the cause, then we're so close to get to the treatment. That's what we really want.
Great. Do all of these disorders include a lack of dopamine, and is that what causes apathy and depression?
Most of these disorders, practically all of them, include a lack of dopamine. Lack of dopamine is what leads to the Parkinsonian symptoms. But lack of dopamine does not lead usually to the apathy. It is thought that the apathy may be more related to serotonin, a different neurotransmitter, but we don't have a real good handle on what causes apathy. On the other hand, we do have a much better understanding on what causes depression. and dopamine, but more importantly, noradrenaline and serotonin really contribute to all of these neurotransmitters contribute to depression. But it's very important to separate what is depression from apathy, because if you are just not doing things and you're kind of sitting there because in part you cannot do things, but in part because you're not really willing to do them, you're not having that that made you move for things, but you're not unhappy, you're okay, your mood is okay, you're not unhappy with the world, then you don't have depression. And if you're getting treated for depression, it's not going to help, because you have apathy. And if you have apathy, you treat it with antidepressants and it's not going to go away.
As most of us here today are way beyond the early diagnosis stage and associated treatments, is there any reason for us to have continued studies and tests, or are we just putting our loved ones through additional trauma?
That's a very good ethical question. And this it depends on how you value life and how you value service to the community and service to science. And it's a very hard thing to say. Certainly when you have a diagnosis, you can help others more likely. You're not going to help yourself. And I think pretty much all the scientific studies do stress that. Whenever you're part of a trial, we never said this is going to help you. We never know that. And maybe it can, but at times it can't. At times we really know that this is not going to happen, and we really say that. But do you want to help others? That's really depending on each person. And that's, this is a decision that is more on personality, on being as you are. But it's so American to give to others. I have learned things here that I have never learned them in other places. I lived in Barcelona in Spain, and I can tell you that Europeans don't think like Americans. They really think more on, this is something that we want to do for ourselves, but not really for others. So I don't want to be a guinea pig and do this or that. And here I never hear that. I mean, really, it would be extremely rare. With my more than 20 years of research, I would say I never heard it here, but I did hear it elsewhere. I think Americans have a different way of seeing the world, and it's so relevant.
Are any of these 4 atypical Parkinsonism disorders genetically carried on?
Most of the atypical Parkinsonian disorders are what we call sporadic, that is, non-genetically related. So that is one thing that most of you should know. If there is nobody in the family that has this disease or similar very related diseases, you're not going to transmit that to your kids. So that's one thing that gives a little bit of a relief. If you do have multiple family members in your family that do have something very similar to what you have, it is very likely that this is familial. And there is a gene that is really determining that. But that occurs in less than 10%, times less than 5% of the people. So it is rare. It's very infrequent.
Do all of these disorders have symptoms of inability to swallow saliva and drool?
Well, in more or less degree, as you saw, it comes to a point that multiple symptoms go together. And swallowing disorders are common. They are. As it is having speech problems. And as more problems you have with speech, the likelihood of having swallowing problems is alike. So in the majority of these disorders, that is a major issue. Even in Parkinson's disease, is a major issue.
One of your slides mentioned frontal dementia. What is this?
Frontal dementia is when you do have difficulty being a CEO, we are all CEOs in our world. Some of us may be of big companies, some of us is from our own houses. But still, you have a function of planning, of multitasking, and trying to do the best with your own finances as possible, right? So when we lose those abilities that are located in the frontal lobes, that's when we have executive dysfunction. And when those problems are so severe that actually are impairing our functioning, that is when we call it dementia. Usually, it does accompany some changes in behavior. In most of our diseases is apathy. There is also some impulsivity, doing things that may not take in consideration the consequences. For example, someone that may have difficulties walking and difficulties with balance may see a little paper in the middle of a room, the living room, and they say, and I'm gonna go and get it. And suddenly when they get up, they just fall. I said, but then the caregiver comes and says, but why did you do that? Why didn't you tell me? And I think that difficulty with controlling the impulse is there. So you go to the airport and you say, sit there, I'm gonna go and get the luggage. And someone gets up and starts walking, and then again, there is a problem. And that is truly what we meant by difficulties and some executive dysfunctions that are disruptive of life. When they disrupt life in significant ways, that's when we call it dementia. But it's a different dementia than Alzheimer's disease. It's not a memory problem that keeps asking, and so, you know, what happened, that you don't remember things, that it's a different story. It's not that you don't remember what you had for breakfast. You may have difficulties retrieving spontaneously the information, but the information is there. You're always there. So as if, for example, somebody calls and you spontaneously don't say who called, but then if somebody else asks you who called, then you say, oh, your uncle called. I forgot to mention that. That happens to all of us, of course. But if it is in significant ways, then that is different. So it's having this difficulty in retrieving information that is there. The difference with Alzheimer's is that the information is not even there. Here, the information is in the brain. The difficulty is retrieving it.
That's all the time we have for questions. Thank you so much, Dr. Litvan.
Thank you for your attention and your beautiful questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.